right, well, we can go ahead and get started. So thank you everybody for joining today. And if you're listening to the recording, thank you for watching the recording. We're super excited to have Dr. Johnson and her team join us again to talk a little bit more about school-based health centers. And if you were here for the first round, you know Dr. Johnson, but if you were not, for some context, if you Google her, she has multiple titles. You'll see her pop up with Emory Children's. She's a wonderful pediatrician. And more context for today, she's really the matriarch of school-based health centers here in Georgia. And she's been doing this work for so many years and is just so wonderful. And we'll be able to answer all of your questions today as you talk to your regions about what implementation actually looks like and what more of the logistical explicit next steps are with school-based health centers. So thank you again, Dr. Johnson, for all the work that you're doing. And thank you for really all the legwork that you've done to make this opportunity available across the state. It's an incredible amount of funding from the governor's office, and we just want to make sure that all of our different stakeholders across the state are aware of the wonderful opportunity.
Okay. Well, as always, it's just great to be amongst a group of folks who I've, in joining some of your sessions and your updates, have come to know. I'm so incredibly impressed by all of the great work that you do. Some of my work sort of pales in comparison to some of the things you're doing in your individual communities. So I just want to applaud you for that and encourage you to just keep up the great work that you're doing, because it really is a game changer in our state. So as always, people who know me know that, I'm always talking about school-based health. I'm always talking about systems of care for children. The reason I went into pediatrics is because I just like being around children. People say, well, what motivated you to do this? Was there any singular event? I'm like, no, I just look into the eyes of a child and I go like, okay, that's where I need to be. And my husband told me, he says many, many times, he says, really, you should have just opened a daycare center. And you know what? I would probably been just as happy opening a daycare center, but I don't think I would have the leverage that I have if I was just the owner of a daycare center, even though, this can be pretty powerful if you're making some inroads. But I think as a pediatrician, I have a larger platform and I have the ability to speak out on behalf of children and families in a way that I couldn't if I were not a pediatrician. So where do we start? Last time we were talking about school-based health centers, I think I went over just, the overview of school-based health centers, what they were, what it takes to take them to scale, and really how and what you're looking toward in terms of your accomplishments and what you hope to achieve by having a school-based health center. I thought we would delve a little deeper into the actual implementation of school-based health centers with this talk. I have with me Sandy Matheson, who is an extraordinary advocate, and Sandy, I always forget what your title is, but she's up in North Georgia. She's going to tell you her title. She's up in North Georgia.
Well, I have a catch-all title, I guess. Okay. It would be development officer. So it's a little bit of everything, but I do primarily work with our school-based initiatives and growth that lends to a lot of growth we've had. So honored to be here.
All right, and that's in North Georgia, Day, Catoosa, Walker County, the whole geographic region up there. And we've been working together for, I don't know, what, 10, 12 years? Yeah, it seems like forever. And they've really done an extraordinary job in not only just, creating school-based health centers, but also creating systems of support for children and the community as a whole. So she can give you more information on actually how to do this, especially in that area, in these rural areas. I've been doing this work for over 30 years, and I don't have tunnel vision, but most of my work has been centered in the urban areas, and she can really speak to what it takes to do this in the rural areas. So I thought I would just go over a little bit on, do a little formal presentation on implementation of school-based health centers, and then I'll have then Sandy make a few comments about the work that they're doing up in North Georgia. And then you guys can ask us any questions that come up. And of course, you can I guess, start to put the questions in the chat as I start my talk, and then I'll let Audrey sort of monitor that, okay? All right, so let's get started. I hope y'all can see this screen. Yes? Okay. All right, yes. So Justin, I just want to, oh, why are we not moving? Okay. All right, I'm not quite sure what's going on with my computer. I do kind of want to just summarize what we talked about before. You know, we started our first school-based health center 30 years ago in Southeast Atlanta, and actually opened a second school-based health center 5 years after that. And for probably the next, I don't know, 15 years, we only had 2 school-based health centers in the state of Georgia. And our goal was always directed around, how do we take this to scale? You know, how do we replicate this model so that more children throughout the state will have the benefit of having these academic and non-academic supports for them as they try to learn. So as we researched the strategies around how you take school-based health centers to scale, we came up with 4 basic elements. The first is that you have to bring in the community and recognize community need and support. You need to increase public will and educate the community around the benefits of school-based health centers, but also understand what they hope to achieve as a result of creating these centers. You have to develop a model that you know is going to be sustainable, because historically, that was one of the challenges of school-based health centers, which have been around for over 40 years, by the way. How do you sustain them? The third is that you have to demonstrate that what you're doing is of value. You have to have some evidence of health and cost impact. And the fourth really involves being loyal to a model that you know that works. We call that implementation fidelity. And these 4 basic elements were sort of captured in 3 phases as we tried to take school-based health centers to scale starting about 13 years ago. The first phase is planning, which we talked about last time. The second is implementation, and the last is sustainability. But for this talk, we'll speak more about implementation. I'm having a hard time moving these slides. I just want to just summarize again the planning phase. The purpose primarily is to galvanize the community around the needs of its children. I think that's probably the most important aspect of this work, is bringing stakeholders together to do needs assessments and to define the needs of their children. The second is to increase public will and knowledge around the merits of school-based health centers. And we do that through community forums and outreach and surveys and focus groups. And the third is to identify a school that is best suited to host the school-based health center, and then to choose a medical sponsor and to secure startup funding. Now, for us, with this particular project, the governor's allocation of $125 million is first and foremost unprecedented, and really takes the worry out of securing startup funding, because we have startup funding for over 100 new school-based health centers in the state of Georgia. This has never happened before, not only in the state of Georgia, but throughout the country. No state has ever had that large amount of funding for school-based health centers. In many ways, we're incredibly pleased by it, and then we're really stressed out about it as well, because we have a very short time frame in which to develop these centers. But we're really excited by the fact that we have this money, and that we can actually continue to take school-based health centers to scale throughout the state. My computer is slow, I'm sorry, you guys. I just want to say a little bit about identifying the medical sponsor, which is something you guys need to focus on as you go through your whole planning process. And to understand that even though in the state of Georgia, we sort of focused on choosing federally qualified health centers as medical sponsors, there are many others that other choices that you can make. The reason that we focus on federally qualified health centers is because their mission aligns with ours, and that is caring for underserved children. And that's really the premise behind most of the development of school-based health centers, is to increase access to care for underserved children in order to improve not only their health, but their academic performance. And FQHCs also get an enhanced reimbursement for their services. So that really lends toward their sustainability. And that's why we sort of focused on FQHCs, but we're really branching out. We really want to focus on the private practice, especially the pediatrician and the family medicine physicians in your community, the hospital systems, any academic institutions in your community, the health department, which historically sponsored most of the school-based health centers throughout the country, but that is sort of decreasing in numbers because FQHCs are increasing. And then other systems like rural networks that we've worked with in the past. So these are some of the medical sponsors to consider. The most important aspect of the medical sponsors is that they need to be at the table during your planning phase because you want to get their input. You also want to address any issues that the community may have around a particular medical sponsor, especially if you're not going with the local physician in your community. So all potential medical sponsors should be at the table when you're doing your planning. So let's talk about the implementation phase. It involves first engaging the school district and the school along with the school board. And with all of the discussions we're having around the challenges of school boards, this can be a really critical phase of your implementation. You need to be able to create a memorandum of understanding once the school board approves it. And the memorandum of understanding is between the school district and the medical sponsor. And we'll talk about that a little bit more. You need to be able to identify a space within the school-based health center, within the school that would house the school-based health center, and come up with strategies for renovation. It involves hiring the core staff for the school-based health center. And for federally qualified health centers, they have to obtain a change of scope approval in order to start providing these services before they can open their doors. It also involves enrolling the school-based health centers into the Medicaid, Peach Care, and other private insurer sites. You have to credential your staff with the individual payers, such as Medicaid, Peach Care, and private insurers. Student recruitment and enrollment is critical, and it involves a lot of marketing and outreach. And finally, you have to establish and monitor your enrollment, your utilization, and your quality metrics. And those are the basic elements that go into the implementation phase. So let's talk about a little bit about the memorandum of understanding, which a lot of you have already probably entered into in one way or another. And it's just a legal document that outlines the mutually agreed upon roles, responsibilities, and liabilities, underscore both liabilities, between the school district and the medical sponsor. And it should include where the school-based health center will be located, who will employ the staff, who will handle third-party billing, which would always be the medical sponsor, who will own the medical records, always the medical sponsor, who will maintain professional liability insurance, who will ensure adherence to federal and state regulations, who will collect data for reporting and program evaluation purposes, and how program decisions will be made. All of that is outlined. We have sample MOUs, just in case you're interested in how they've been established. And they have been, some of our sample MOUs have been vetted by the best school lawyers in the state. And so they should pass the muster with any school district that you may be working with. The second has to do with identification of the space. It's best to have a school-based health center in the school, even though when you're limited with space within the school, you can go to modular units. It's not necessarily standardized, but we do recommend that for every 700 students, you have a space between 1,500 and 2,000 square feet. That will give you about 2 to 3 exam rooms, a lab, a mental health room, a waiting area, some office space, and then sometimes like a transition space as well. Like I said, it's best to have the school-based health center in the school because you have greatest access to the students and staff. And even if it's in a modular unit, children have to leave the school, the facility itself, and that in and of itself increases your liability. But if that's your only option, then that can be worked out quite nicely. The modular unit is usually right adjacent to the school building, not too far, so the children don't have to venture too far away from the building. It is the best module for community use, and Sandy can talk a lot about this because they have been using modular units up in North Georgia and also space within the school. Like I said, it has increased liability because children leave the school, and also there may be some increased safety concerns as well. But it does work well if you plan for it, and sometimes you can have like create a breezeway and a connection between the school facility and the modular unit. But it's a good choice as well. So the renovation of the space, this has been a real challenge for us throughout the state. When we opened the first school-based health center, 30 years ago, the school actually renovated the space for us, and it's a lovely space. It ended up being about 2,000 square feet. They decorated the space for us. I mean, they took upon the entire role of doing it. And oftentimes it is the responsibility of the school district. However, you can get funding outside of the school district from foundations or government agencies to do these renovations. With this current funding, there's over $300,000 allotted for school renovations. And so no one has to worry about, raising those dollars or trying to figure out if they have enough funding to do the renovations. Since COVID, the cost of renovation has almost doubled. When we renovated a couple of centers about 7 years ago in the APS system, we spent about $100,000. We're currently renovating a space in DeKalb County for a school-based health center, and the price came back at $400,000. I mean, it's just amazing how the prices have increased. But I do think on average, $300,000 would be more than enough to renovate the space to accommodate the school-based health centers. If it's within a modular unit located on the grounds, usually the cost is a negotiation between the school district and the medical sponsor. But with these the funds that the governor has allocated, you can use those dollars to purchase a modular unit. It usually has to be customized, in order to meet the needs of the clinic space, but you can either renovate a space within the school, or you can actually purchase a modular unit. So the staffing, the funding, the staffing of the school-based health center is a responsibility of the medical sponsor. We hear a lot of school districts trying to determine, well, do we hire the social worker? Do we hire the behavioral health people? We say, no. You can actually come up with some sort of collaboration where you can share employees, but in general, the staffing of the school-based health center is the responsibility of the medical sponsor. The core staff usually includes a physician who may or may not be present within the school-based health center, but they at least provide oversight to the advanced practice practitioner, who's either a nurse practitioner or a physician assistant. They are always part of the core staff. You need a medical assistant. When I started many years ago, I actually had an LPN and an RN, but you really don't need someone with those high credentials. A medical assistant will suffice. You need to have a licensed clinical social worker because all of these programs that we're developing in our state is going to have a behavioral health component to it. And you need to have front office support. Initially, we didn't include front office support either because we thought the medical assistant could be front office, back office, but we found that, when you increase your productivity, it's too much of a responsibility on the medical assistant to serve both as a front office person and to assist the provider. You can also add additional staff as funds become available, such as a dentist, dental hygienist, optometrist, and as you can see, the others. And some members of the core staff, especially with behavioral health and dental, can be provided and funded by organizations outside of the medical sponsor. I'm thinking of our APEX program here in Georgia, where you can actually collaborate and integrate your work within the school-based health center with the providers from the APEX program. So you may not have to hire an LCSW, you just integrate the LCSW who's part of the APEX program into the entire school-based health clinic staff. And the same with dentists. When I started many years ago, I used the dentist from the health department to actually staff our school-based health center. We had a 2-chair dental operatory. We didn't have a dentist, but we collaborated with the dentist in the health department and worked out, very well for at least 2 years. These are some of the job descriptions, which I won't go over in too much detail. As you can see, the medical director or the pediatrician is usually a 0.2 FTE. The advanced practice practitioner is full-time, medical assistant is full-time, and the same for the licensed clinical social worker. If you have a dentist or dental assistant, they don't necessarily have to be there every day. They can be part-time, especially if you have more than one school-based health center. They can serve many school-based health centers, and maybe Sandy can talk a little bit about that. The front office person, health educator, as you can see. We had a full-time health educator with my first school-based health center, who was funded through I forget. It wasn't HRSA, I can't think of it. Maternal and Child Health is who they were funded through. And she actually went into the classroom every day and provided all of the health education that normally teachers would provide, in addition to individual and group health education. And then a community outreacher we're finding to be of much more critical to the needs of our families right now, so they can serve that liaison between the families, the school, and the school-based health center. So this is important to note. School-based health centers do not replace school personnel. They do not replace the school nurse. They do not replace the school counselor, but rather they complement services already provided by the school nurse, counselors, and family liaison workers. I always say the purpose of school-based health centers is to not only provide the needed health needs of these children, but also to help teachers and school staff be able to do their job better. So they're not here to replace them, they're just here to complement their work. It's also important to note that school-based health centers adhere to HIPAA, confidentiality, and that, of course, the schools have to adhere to FERPA, and never the two shall meet, right? The only way that you can share information between the school-based health center and the school to the school-based health center is that you get consent from the parents to do so. You just can't assume that just because you're under one roof that you can share this sensitive information between the two. You can't. You have to have parental consent in order to do that. And it's not hard to get, but you have to go through that step. A little bit about what FQHCs have to do in order to get prepared to implement the school-based health centers. First, they have to get a change of scope. And the scope really defines the health center's approved services sites, services providers, and the whole gambit. They have to apply to HRSA in order to do that, and it takes them up to about 60 days. So you really have to plan ahead. If you say you want your opening date to be a particular time, that you have to do your application at least 60 days before you want to open your school-based health center. So it's called a change of scope. You also have to enroll the school-based health center into Medicaid and all the other insurers. You have to credential your staff with Medicaid and the other insurers, and it can take up to a year to do this. So you have to be really proactive in getting all of your credentials completed and entered into the system. You can actually start seeing patients before you're fully credentialed, because you can do back billing to a certain extent, but this takes a while. So you need to plan ahead in order to make sure that the center is enrolled and the staff is credentialed. The next aspect of implementation involves student recruitment and enrollment. This is probably the most daunting task of anything you have to do in terms of implementation. It is an ongoing effort. It never ends. Even after you start your school-based health center, for years on end, you're going to be recruiting and enrolling students into the center. And you really have to focus on this through your marketing efforts and your outreach. It should begin, and marketing and outreach really should begin as soon as the school board approves the project. That's usually at the very beginning of your planning period. And because it just really requires a lot of effort to educate families, for them to understand what it is you're trying to do, and to address some of the issues that may come up in the community, especially with the private physicians, with the pediatricians and the family practitioners who may feel a bit threatened by your school-based health center, who may think that it's competition or that the quality of your care isn't what it should be. And so you really have to start educating the community, parents, and everyone around the value and the merits of school-based health centers. One of the ways that you enroll the children is that you have to get consent. Every child who is seen within a school-based health center has to have parental consent. You cannot see a child without the parents consenting to it. And so this is really sort of an interesting task because it takes on many elements. Historically, we used to just send consents home with the children, you know, and hopefully, you know, hope that the parents actually see the consent and that they complete it and that they send it back. But we found that it works even better when parents are coming to enroll their children, when they're coming to register them, that they get these documents then, and we start educating our families about what we're trying to do with the school-based health center. You can also distribute them at the parent-teacher, the PTO meetings, health fairs, and other school activities and community events. But it is, you know, it just takes forever sometimes to actually get these children enrolled, because it really takes a long time to educate our families about what it is, what a school-based health center is. Most parents think school-based health centers is just a nurse's office, and they have to see it in order to understand that it's different from the nurse's office, and it really is a doctor's office in the school. Of late, we've been adding electronic consents to the school websites and to the medical sponsors' websites, and we also have links that we can send to families about how they can sign, complete the consents. And again, the marketing and outreach is just, oops, I'm sorry, I'll go back. The marketing and outreach is not just confined to the school, but it's also it also involves community-based activities as well. Historically, our goal in terms of student enrollment is that for the first year, we would like to enroll at least 25% of the student body, 50% by the second year, and over 70% by the third year. I'm just going to say a little bit about marketing, which is a key component to implementation. It really requires a creation and distribution of flyers, brochures, newsletters, and other forms of written communication. Again, you have to include the school-based health center activities and the definition in your school websites. We do press releases. We are starting to use social media now in order to identify the needs, the value of school-based health centers, and to talk about specific activities that happen within the school-based health center. We do public service announcements, and again, we do presentations at school and community events. I want you to note that marketing, as I said before, is continuous, but it's also collaborative. It's a collaborative effort that's shared by the school personnel, staff, students and their families, the advisory council members, and other community advocates. You cannot market, the school-based health center cannot market on their own. They do require
the shelter. They Dee is the one that went and got that, and
I'm sorry. Okay, maybe somebody was talking without knowing it. So anyway, so it requires this enormous collaborative effort between everyone who has a stake in the school-based health center. And then you have to come up with some quality metrics. Remember, I was telling you, in order to take school-based health centers to scale, you have to demonstrate impact. You have to demonstrate that the school has value, not only with in improving the health of the child, but also the academic achievement of children. And so you have to establish and monitor the metrics on patient enrollment, on utilization, and very specific health and academic issues, right? So I usually focus on asthma, I focus on mental health issues, well child checks, and critical risk assessments for children, and also obesity. So those are some of the markers that we've developed in terms of in terms of demonstrating the impact of school-based health centers. You can also use this monitoring as a quality improvement tool, not just to capture data, but also to see whether or not you're accomplishing what you hope to accomplish. And when the data is collected, it should demonstrate, like I said, the value and impact of school-based health centers on the overall well-being of children. This is a sample of a data collection tool that we created. This is just part of it. And as you see, this part is just really captures enrollment and utilization. Like I said, we have another page that captures quality metrics on asthma care, obesity, health checks, and mental health. And we'd be more than happy to share this with you if you'd like to see it in detail. Finally, I just want to talk a little bit about advisory council, which is critical to not only the planning process, but also the ongoing efforts to create metrics for the health center and to monitor the activities and the value of the health center on the well-being of the children. So you need to establish a school-based health center advisory council for the purpose of providing oversight and advocacy for the school-based health centers. Members of this group can come from your planning phase, but you'd probably need to add additional members as you define exactly what your services are going to be. The staff from the school-based health center has to be included in your advisory council because they are informing the members as a whole as to the activities, the successes, the challenges of their services. And the advisory council will assure quality and alignment of services between the school and community and provide guidance and feedback as needed. At minimum, the council members should consist of school administrators, the medical sponsor, the school nurse, and other school personnel, such as teachers and counselors, the school-based health center staff, and parents and community members as a whole. I strongly emphasize that parents play a vital role in your advisory council because because it's important for them to have a say into how these services are created and delivered. But we are also in a climate right now where parents' voices are critical to provide services in the school, no matter what they are. They have always been critical, but it's really been, is somewhat of a challenge right now in trying to define how far we take that. But I do think it's really important to have parents on your advisory council so that they can, first of all, understand what you're doing, but also serve as an advocate for you. And then finally, I'm just going to briefly go over this adjusted timeline for implementation. It usually takes about 2 to 6 months for the board to approve. Sometimes it takes longer, as we're experiencing in some of our centers right now, but usually about 2 to 6 months. It takes about 3 to 6 months to create and to fully execute your memorandum of understanding. As it stated before, the FQHC requires 3 months or more to get their change of scope, just in case you're using an FQHC as your medical sponsor. Now, if you use someone else as your medical sponsor, this is not going to be an issue. Site enrollment with the insurers takes between 3 to 12 months. I said 3 months because we've had some sites that really, they were able to have their sites enrolled in 3 months. I think they had it in with the state Medicaid system in order to do that. But historically, it takes about 12 months. It takes about 3 to 10 months or longer to actually hire staff now. You know, we are really struggling with staff shortages, especially in terms of nurse practitioners and LCSWs. So you really need to get started on that fairly quickly. The student recruitment enrollment is ongoing. It never ends. It begins early on and it never ends. So you should start as early as you get board approval. And then clinic utilization is really dependent upon getting parental consent, educating the parents in the school system about the value and the appropriateness of referrals into the school-based health centers. It has to do with appointment scheduling and all of that. And it really is strongly dependent on outreach and marketing. All right. So that's the end of my, I hope it was a short presentation on implementation. And if you have questions, I'm going to open it up to you. But I would like for Sandy to just say a few words about, to describe the great work that they're doing up in North Georgia, the processes that they've gone through, some of their challenges, some of their enormous successes, and then we'll take questions.
Oh, thank you, Dr. Johnson. Well, we have been doing this work, like Dr. Johnson said, over 10 years now, with our first one starting in rural Georgia up in Tunnel Hill, Catoosa County. And we had a planning grant and started that work and engaged the school system at that time. I think we were one of the first 4 to 6 in the state, Dr. Johnson, way back then. So we were very eager to start this work. We are more of the rural model, as Dr. Johnson said. So we're in a farming community is where we first started. But a few things, as the planning is so important. Starting that 18 months or a year ahead of time and building consensus and building those partnerships. We work very closely with the collaborative. We work very closely with engaging other physicians, pediatricians in the community, business owners, family members from the school. We had some that were really on board that we involved, like Dr. Johnson said, the parents. And it is truly a work that's ongoing once you get started. You like she said, the outreach and the marketing is continuous. Even today, if some of you heard me earlier before everybody got on, this is school teacher appreciation week. So I've been at all of our schools this week taking lunch or goodies to our school teachers. And your teachers are the ones oftentimes, and your school staff, your registrar is a very important person at the school to get engaged early on. And then helping them to know that for some of our school systems, we had full-time school nurses and they were like, what's going on, but we work hand in glove with the school nurses. That's so important. And that is not going to increase the school nurses' work. But in other of our schools, we don't have a school nurse in every school. So that's a really important key. But the marketing piece is so important. We work very closely with our school and we're blessed that they are on board 110%. So starting early, getting that superintendent engaged, making sure that you're talking to the right people in the school system. We were lucky to have in all of our schools, school board members that were eager and on board as well. But keeping that constant communication with them is key. So we have Tiger Creek that we opened a little over 10 years ago. And then a couple of years later, we opened in West Walker County in a very rural area at Gilbert Elementary School. And then we also have now, and those are school campuses where we have a modular on campus. And I'll talk a little bit more about that in a minute. But then we have also recently opened 2 school clinics within the school at Rossville Elementary and Rossville Middle, and we are also in Ringgold High School. And those are school clinics that are open during the school that are housed in the school. The other 2 that we opened first, we knew that there was a need and there was lack of room in the schools for us to have our school clinic. The first year at Tiger Creek, we saw only the teachers and faculty, which we also care for. And the teachers love us because they can come in if they've got something going on. We open at 7:30 in the morning. They can get checked out and then go on to class, get their medications, whatever they need. But so the first year after we opened at Tiger Creek, we opened only to see faculty and children. And we were building trust with the school board. And then by the next summer, they were like, we want you to be able to see the community. Because what we found was oftentimes we would get the students engaged and they would have Medicaid, but many of their parents did not have insurance. And we are an FQHC. So we started seeing family units. We started seeing parents, siblings, and a lot of grandparents and other relatives that are caring for those children that are in the school system. We have worked endlessly and tirelessly in the community to make sure we're involving key people in the community with our school-based programs. We are lucky in that we've been around for 43 years as an FQHC, and a lot of folks already knew the work we were doing, and our mission, like Dr. Johnson says, does align very closely with the work that the school-based programs are doing throughout the nation of providing quality healthcare and access to all those regardless of ability to pay. I'll talk a little bit about getting the children registered and in the system. That's so important. And Dr. Johnson's slide have had the first year of having 25% of your students and then the next 50 and 70%. We've found and worked really hard. We want to be seen as an integrated part of the school system, But the schools that we work with allow us to send home the school-based healthcare center registration information at the beginning of the school year with the regular school registration information. That has been a key for us because the parents look at that as part of just their school registration packet, and they fill that out and send that back within that first week or two of school. We are working to be able to do that electronically. We have not gotten there yet. Some of the school-based centers are doing that and doing that successfully. And we also have the patient sign up on the website and on the portal. So we are included on the school-based website, and as well as them being able to go onto our website and sign up. The schools also promote us. Most of your school systems have a text alert for all your parents, and they will put out messages, whether it be we're doing school physicals or anything that we're doing. They put that on their signs out front for us. They put that in their text messages. They are on board 110%, and they know now that they have seen the decreased absenteeism, the increased seat time, and they see the benefits of what we're doing. And when Sally gets checked out, usually the other siblings would get checked out, and so you're seeing the children stay in school. If they don't have anything contagious, then they go back to class. We struggled a little bit during COVID. We did a lot of telehealth. We were already ready and doing telehealth, but we are working hard now. What we have found over the last 2 years is children weren't coming in for their wellness visits and their immunizations during COVID, and we're trying to work to get those children caught up. We're being intentional. We take grade level by grade level before the end of the year and do physicals on these students and give them the opportunity to be seen if they have, if they haven't and they're behind on that. There's just so much something more recently we've been doing that we were asked by the schools to do is hygiene classes for the 4th and 5th graders. And the teachers and the parents had asked us for that. And we're very general in that. We talk about hygiene and some things, but basically overall your outreach and marketing is ongoing. I'm doing the same marketing and outreach, and our staff are doing the same marketing and outreach we've been doing pretty much since we opened. It's a key component of it. At our school-based health center, we have behavioral health, we have dental, and we also have nutrition and dietitian services. So we're very comprehensive in our care. We work very closely with the entire, even though our school-based health center may be housed at one school, we provide services to the entire county campus. So we work closely with the homeless school social workers. They know that they can contact us. We work closely with whatever your county's truancy group is called. They know they can contact us if they're having issues. Just building that rapport, building that working relationship, and having them know, at our school-based health centers, our superintendents use them. I mean, what better marketing and outreach can you have than that? They say, hey, we need to be seen, and they get in. Dr. Johnson, what have I forgotten you want me to hit on? There's so much to talk about.
Yeah, you've done a great job. I guess we can, thank you so much. It's a wonderful overview from the ground level of what it takes to do this work. I guess we can entertain some questions now, sort of direct the conversation.
I'm getting in the chat so I can share them. So, and first I want to say thank you so much, Dr. Johnson and Sandy. This has been like such an amazing amount of information. I'm very grateful to you. So what does the medical director usually look like? How do they manage a 0.2 FTE? And do they have like another position? And what does that look like in different parts of the state?
Yeah, so I'll just say in general, and Sandy can say exactly who their medical director is. So it's usually someone within the medical sponsors organization. It could be just a regular pediatrician. It could be the medical director of the FQHC, but they need that time allocated to supervise their nurse practitioner or PA to provide consultation for them, to do chart reviews and peer reviews, but also at times to actually go to the center and care for the more complicated patients that the nurse practitioner or PA are not able to care for. And so we put 0.2 because historically that's what it's taken, but sometimes you can do it at 0.1, all right? And then you have some, school-based health centers where the pediatrician is in the center, who's actually the provider of record and can serve as both the medical provider and the medical person oversight. So that's historically how it is. That 0.2 is allocated toward that kind of activity. I'll let Sandy sort of explain who actually does hers.
No, we are, well, first of all, if we're able, now hiring has been more of a challenge. We always try to hire a local nurse practitioner from our community that our school-based healthcare center is housed in. And a lot of times they have great relationships. But so we have a nurse practitioner, a medical assistant, and most of our clinics have 2 to 3 exam rooms. They have oversight by, we have a pediatrician. And we were just blessed with a pediatrician that retired from Kaiser Permanente. He's fabulous. So he gives oversight. And then we also, with your FQHCs, if you have a partnership with them, that most of them have a chief medical officer that also provides oversight. And, the other thing that there's no, as Dr. Johnson says, there's no replacement for actual hands-on children. But in our case, since we have been doing telehealth far before COVID ever hit, probably for 7-8 years. And if they need to get a second opinion, sometimes they will, and the pediatrician isn't on site that day giving oversight, they can connect with telehealth with our chief medical officer or our pediatrician as well.
Thank you. What are some benefits for the FQHCs in being a medical sponsor?
Some of the benefit, as Dr. Johnson said, we do get increased reimbursement. But for us, we're very mission driven. And so it's truly about reaching those that need to be reached and providing those services in many of the rural areas. And I think probably in part of the urban areas too, we still have a problem with people not coming for care, for preventative care. And so, they only come if they have a toothache, if they have an earache. So working, as a FQHC, we're very focused on prevention and getting people in for their annual checkups and heading off major illnesses. So that's, a big benefit for us.
They also, most FQHC, well, all of them have quality metrics that they have to abide by, that's dictated from the federal government, which is unlike a private practice, right? And so they already have embedded quality metrics that really lend to the quality of care that they provide. I'm just going to make a brief comment on, there are some challenges though. We always say if you've seen one FQHC, you've seen one. They're all different. They all have their strengths and their weaknesses. I think one of the biggest challenges for anyone, whether it's an FQHC or any other medical sponsor, is that you have to behave differently in a school than you do in your practice. And that you're basically at the mercy of the school system and what their requirements are, and sometimes what their quirks are. And so you have to figure out a way to change your approach to caring for, to providing services in a school-based health center setting, right? And there are certain things you can and cannot do that you would normally do in your other facilities. But the most important aspect of this work is becoming fully integrated into the fabric of the school. And it takes a while, and it's a learning curve for a lot of them, but you need to go into it understanding that and being prepared to do that.
I'll tag onto that, Dr. Johnson. We always say we need our warm, fuzzy people to be the people at the school-based healthcare. The ones that like to have the hugs run up and given around the legs. But right. Yeah, so you do need the special kind of people to work in your school-based healthcare center.
Yeah.
Extremely diverse. Can you address how language and cultural needs are addressed in service provision?
You're breaking up. You were breaking up.
No, try again. So this question is from Gwinnett County, which is very diverse. Can you address how language and cultural needs are addressed in service provision?
That's a great question, because we're going through it right now. We have a new school-based health center in Doraville, D'Urville United. And it's about 98% Hispanic, but they're from all over the world, to tell you the truth, from South America, Mexico, Central America, Puerto Rico. I mean, it is so diverse in general, but the language issue is a huge, huge barrier that we're dealing with right now. And we have one person in the health center that actually speaks Spanish, but it's a different Spanish, right? Because there's some dialects in South America that we still haven't quite figured out how to get interpreters for. And so the language barrier is a huge barrier in many ways, not only in terms of providing care for children, but also helping the school system understand what the needs of children are. For instance, we've had a number of children sent to the health center because the teachers thought these children had ADHD. They had lack of focus. They were basically hyperactive. They were inattentive. They were not learning well. And they said, these children have to have ADHD. And then we would respond and say, well, it may be because they don't understand what you're saying. It may be because they've been traumatized on their way here to America. It may be because for one of the children I took care of, the first time she ever entered school was in the 3rd grade, and she had never gone to school before then. And so helping the teachers understand the unique needs of these children based on their experiences is really complicated. The other thing really has to do with culture and trust. It sort of reminds me of rural, where you really have to, create an exceptional level of trust in order to get people to participate. It's the same way with a lot of our diverse populations, our immigrants, our refugees who come into this country. They don't know why we're asking them the questions we're asking them. They think that, sometimes they don't want to disclose anything because they think we're going to use it, against them. And so we spent a lot of our time trying to convince our families that we care about them, that we will not share any information, and that we want to understand from their perspective what their challenges are. That's a really critical piece of being culturally competent and sensitive, is that you ask them, you don't assume you ask them what their concerns and what their needs are and how they interpret your interactions with them. And so it takes a lot more effort when you're dealing with diverse populations, especially those from other parts of the world, but you have to approach it with that in that manner that first of all, you don't understand, you need to ask, and that you need to really learn about the culture in addition to help them navigate the system.
I was just talking to an FQHC yesterday. Was it yesterday? I think it was yesterday. No, it was Tuesday. And he was saying he was working with groups that were driving all the way to Orlando for healthcare because they had built a trusted relationship down there and they weren't aware that an FQHC in Georgia would treat them the same way. And just the knowledge wasn't there.
Exactly.
Wow. We have, of course, we see Undocumented as a FQHC, and we've, that relationship with the school social workers. We have Spanish speaking and bilingual in most all of our staffs, and we also use a language line. But like Dr. Johnson said, you have Guatemalan Spanish, you have so many different dialects in Spanish, but we have been fortunate to also have Hispanic providers. And I remember last year we had somebody that had come up from the border, and we pulled, all our services together, behavioral health, and were able to provide. So she had a really rough time. She'd come from the border, and then they took her to New York, and somehow she landed in rural Georgia. But it was a win and a success case for us, and we were so glad we could provide that services for her. And she continues to see us today, but she had been through a lot of trauma coming up and getting here, and and working together collaboratively, we were able to take good care of her.
Indeed. A funny story about Language Line. I was using the Language Line a couple of weeks ago, and it was a mother, her older daughter, and the student. And so we have visual language lines where we can actually see the people who are interpreting, and you can see their body language, which is really critical as opposed to just audio, right? And I was constantly repeating myself, trying to, and he didn't quite, it seemed as though there was a disconnect between him understanding my question and then him responding to my question in Spanish. And about midway through the encounter, the teenage daughter started translating for us. she was translating for the interpreter who was in, and then was translating for the mother. I thought it was hysterical. I looked at her, I said, we could have used you from the beginning, you know? So it's just really complicated. The other point I want to make about being culturally relevant and sensitive is that you do learn from others, right? You just don't assume that you're going to understand this stuff, even as you're trying to communicate with families. And so we have community organizations that really help us, that assist us in learning how to approach our families and how to address their needs in a meaningful and effective way.
And I'll add to that. When we started doing some work in Polk County, Georgia, we found that very thing. We found that parents would check out their children out of school to come and interpret for them. And then once they came to our clinic and they found out that you know, we had bilingual staff there, that it was almost, you could see the relief on their face to know that they could leave their children in school. So, and that we had people that, you know, they could speak their language with. So it's, you learn where it's about serving those that are there in the community. And, you know, sometimes with the school-based healthcare center, you go in there with a preconceived notion when you first start the planning and the work. Well, we need to be there 8 to 5 or a certain hours. And I get, you know, one thing I would say is after we go in a community, sometimes we've gone in and opened a certain hour of time. We found that maybe parents need us later in the day as opposed to earlier, or they need us earlier. So we're in a planning grant now with Dade County, and our surveys just came back, and it was interesting. They're saying that they would like for us to be there longer at the end of the day. So I think that's another key, is finding out what your community's needs are. And one school-based clinic is one school-based clinic, and every community is different. And I look at them like people. Every person's different and their needs are different.
Right.
I love that. You shared such powerful stories. I have another question from the chat. How are prescriptions handled for under or uninsured kids and families?
So I'll just briefly, Sandy could talk about their insurance program. I forget the name. I forget the number.
340B.
340B, right. That's what FQHC's. So there are many options. Sometimes some better than others. Put it that way. So we here in Atlanta, we actually go on the website to see where the discount drugs are, and then we actually provide prescriptions based on where we know they're going to get discounts, you know, GoodRx or whatever, to help our families do that. We do also use the 340B program because this particular school-based health center is sponsored by an FQHC, and they get their drugs at a discount. And then sometimes actually we'll have samples, or we'll have the medications in the clinic that I can distribute, you know, for the entire duration of treatment. And so those are for special drugs. I used to do that all the time for Griseofulvin because there's only one producer in the country for it. And if you don't have insurance for it, the cost is prohibitive and you can't buy it. So I would have like a 1-month course of Griseofulvin that I purchased within the clinic. So there are many approaches to it, but you go into it understanding that that's going to be a need, and you need to have something in place in order to address those that are not insured or underinsured.
So I would just add, sometimes, you know, in the state of Georgia, most children should have Georgia Medicaid of some kind. But sometimes, you know, they haven't reapplied, or their spin down has gone off. But we have several ways. So that would be addressed by our social work case manager to get their Medicaid reinstated if that's the case. And occasionally you do have medications that for some reason or another that are needed that are not covered. But we do have the 340B program, which as a FQHC allows us a great discount for medications. But we also have, we work with the school social workers. They have McKinney-Vento also, but then we also have part of that community outreach and partnership is And as you're building consensus as a community, we actually have a patient assistance fund as well. And that comes from a partnership and a collaboration with a lot of churches and social work and civic groups in the community. And sometimes you might have it might not be a medication, it could be a medical device or something that a patient might need that might not be covered. So we work as a team and make sure that none of our patients go without whatever within our reason of, being able to take care of that patient and that student to make sure they get those medications they need.
So I saw the question, what it said, Medicaid for undocumented. No, undocumented children do not have
Right.
access to Medicaid. No.
So that would be a case where we would work with the 340B
Yeah.
program or, our patient assistance fund, or with the schools, they have some funding too to help. So we work together to make sure that they have what they need.
Right.
So what does school-based health center obesity treatment look like, especially considering increased BMI data since pandemic? And
well, it's the same as it would in the private doctor's office, right? So we have protocols for that based on the level of obesity. And so what we do, which is modeled after what I do in the primary care clinic at Hugh Spalding, of course, you do, a good history, you do a lot of diet and exercise counseling, but you also look at their risk factors, right? So you check to see what their hemoglobin A1C is, to see if they're pre-diabetic or diabetic. You look at their liver function to see if they have any type of infiltration into their liver. And looking at triglycerides and cholesterol levels. But there are other things that you can do that you normally can't do in a private doctor's office, and that you can set up special programs to address activity and diet in a school setting, right? Many years ago, I had a fitness program as a part of my school-based health center because I had started to diagnose type 2 diabetics for the first time in my career. Matter of fact, the first type 2 diabetic was 10 years old. And I was just floored by it because historically I had never done that before. And then after that, I had children who were hypertensive and other type 2 diabetics. And so I said, I got to do something to try to decrease the risk factors. And so I created this fitness program. It was an after-school program with exercise physiologists and nutritionists, and take them on field trips into the grocery store and prepare meals and do all of that. And the beauty was that I had access to these children. They were a captive audience. And we were able to see a reduction in their risk factors, both in the elementary and middle school, as a result of our work. And so there are things that you can do in the school because you have a captive audience. You can do a lot of health education within the classroom. You can talk to the PE teacher to get a better understanding of what they're actually doing in PE and some things that they could do better as a result of this increased incidence of childhood obesity that we're seeing. And so not only do you just do sort of the customary medical interventions, but you can do some other things that really, improve a child's physical activity level as well as their diet.
I'll interject. We love being in elementary schools and doing preventative work early on. So we are blessed to have a very wonderful nutrition dietitian department. And we've done a healthy cooking class with things that don't require heat with 4th and 5th graders. We've also done quarterly, we'll have a healthy tasting. And we found out some fascinating information. And what we know is it's cheaper to eat bad and poorly and eat junk food than it is to eat healthy food. And so we found students that never tasted kiwi, they've never had Greek yogurt. And we found that kids love Greek yogurt and bran flakes. Who would think it? But so introducing healthy food to students, and then they go home and sending them home with a healthy recipe, and it begins to break cycles. And so we've seen that our students, of course, some of our students require more in depth, and we'll have you know, if we find that we have a large amount of type 2 diabetes or type 1 diabetics, or things change and ebb and flow from the school year, we'll address that. And then we've also seen more recently, we've actually working with some students in the high schools, we're seeing anorexia and some of the other problems that our dietitian and nutrition team are addressing. So it's great to have that as a resource. And that's one of the things I think a lot of the FQHCs are using dietitian and nutritionists to work closely within the school system and at your school-based health centers.
So we've exhausted the questions in the chat. I would love to open it up if folks wanted to come up. Oh, Shanae, please. Please, we'd love to hear from you.
Hi, thank you so much for the presentation. I had a question regarding the area of sexual health for young people. I'm in the Albany area, and I know Albany Area Primary Health Care many years ago at their school-based health center in Terrell County did a focus on AIDS prevention, STD prevention, the first of its kind where they actually held STD testing in the school-based health center. So are there any promising practices centered around teen sexual health?
In Georgia?
Bible Belt, yes.
I was waiting for a snarky comment from someone.
All right, so this has always been an issue from the very first 30 years ago, you guys. When we told them that we were going to target elementary school, the first question from one of the funders was, what are you going to do about reproductive health? And I said, well, I don't plan to do a whole lot. These are like little bitty children, even though we know that children are exposed to things earlier and earlier. I said, but we have no intentions. Plus, the state of Georgia prohibits it. They will not allow us to do reproductive health activities. You can do sex ed if it's abstinence-based, but you really can't do reproductive health in the school. You can't take care of a pregnant teenager. You cannot do birth control. You cannot, pass out condoms. You can't do any of those things technically. But, we have 188 school districts, something like that. 100 is a bunch of them. And they're all autonomous, which is really interesting to me. Even though they have requirements from the state, they basically can decide as a school district what they will and will not do. And that's what happened in Terrell County. When they told me, so they had a CDC grant around that involved AIDS education, HIV education and AIDS. And when they told me they were interested in doing school-wide STI screening, I said, really? They said, yeah, the school superintendent signed off on it, the school principal signed off on it, school board signed off on it. I said, well, what did the parents say? They said, we don't know. I said, you better find out what the parents, feel about this, because they're going to be the ones that go to the local news and report that they're doing some things that are against, that parents are unaware of, and clearly against their wishes. And I said, if nothing else, just inform them of what you're doing. Just don't do it just because these other folks are doing it. Other groups are saying it's okay. You really need to get input from the parent. And they did. And they were able to do a school-wide screening for GC and chlamydia. And which is interesting, they thought they were going to find a really high prevalence of it, but they didn't. But that's unique, right? And so each school district has the autonomy to do some of this work, but you can't start a school-based health, you can't develop a school-based health center with the premise that these are the things that we're going to do. You will cut yourself off at the knees immediately because there's someone who's going to come up and object to what you say you're going to do. So I said, there are other things, that comes as an integral part of being the patient physician doctor relationship, is that, when we had the middle school-based health center, whenever a student requested that I do something that I knew was in violation of that mandate, I said, well, if your parents say I can do it, I'll do it. And so if you want me to do a pregnancy test, or if you want me, if you want to get on birth control, you're going to have to, the parent is going to have to agree to it. And they said, okay. And I have to tell you, 9.9 times out of 10, the parents said, okay, yeah, absolutely, do it. The other aspect of this work is that if a child comes into the exam room with doors closed and they say, I have this problem, I have a vaginal discharge or, whatever, I'm going to take care of it. I'm not going to, advertise it to everyone that that's what I'm doing because that's no one's business. But as to be, a comprehensive quality physician who's going to care for my patient no matter what's going on. I have to be able to do that. And they don't have to know what I'm doing, right? But there's a lot of other caveats and nuances that's associated with that in terms of if you're going to bill for it and the parent doesn't know about it, and then if they get the report, all those things come into play. But for the most part, with these children, I'll say, the other wonderful choice we had is that we had a teen clinic down the street. And oftentimes we just refer our children to the teen clinic. But within the confines of the school, you're really going to be limited in your ability to do reproductive health. And things are going backward. They're not going forward in the state. So I don't anticipate any major changes in that. But there are, conditions in which you can properly care for the reproductive issues of your patient without, getting into trouble.
Oh, well, I'm happy to hear that we were a part of that. So not my current agency, but we were the partnering agency with AAPHC.
Oh, okay.
The CDC grant. So I didn't know that it was foreign to the state. I thought that other folks were doing it too. So.
Oh, I was so nervous. I was like, okay, you guys, really? You're going to do this? I'm going to undermine their clinic. I don't want somebody to come in and shut them down because of that one little thing. But they handled it really, really well. And so no bad repercussions as a result.
Yes. Okay, thank you.
I would tie into that. We had, when we opened 10 plus years ago in Catoosa County, we had a board member who was Catholic, who the only vote against opening on the school board level was, even though we were elementary, you're going to be passing out birth control. And, so you just have to be very cautious, I think. But for us, building that relationship and that trust and being on the school campus, and that's, a private appointment, a private conversation with the provider. But it's so valuable to be able to be in the schools and build those through our hygiene classes. I'll tell one story and then I'll be quiet. But we had a little girl that came up after to our nurse practitioner who had recently lost her mother. And, she had just some questions about becoming a woman. And so she was able to go over and see our nurse practitioner and just build that trust and be able to step in and help some.
I'm just so grateful for all the work that you do. Are there any other questions in the Zoom room? I did want to share that I believe that they're going to release a letter of intent for superintendents maybe around June, and they'll be asking for that to come back a month later. And then there's going to be another round, a request for applications maybe around September 1st. And then that will be again asked to come it'll be due a month out. So that will be coming out. I will definitely find out when that comes out and share with the group. But I'm just so excited that we've had such like an in-depth conversation. I really appreciate Dr. Johnson, your time, and Sandy, your time, and everyone on this call.
I appreciate it. I do want to encourage you to reach out to your school superintendents, to encourage them to apply for this next round of planning grants for the governor's dollars. A lot of these schools, especially the small school districts, they really don't feel as though they have the capacity to do it. But if you can partner with them, they can actually accomplish this. And so I just encourage you to reach out to the superintendent or local, if there's a really vocal principal who wants this in their school, who they in turn can reach out to the superintendent, because it has to come from the school district. It cannot come from the community, but they can work with the community in order to do this work. So I just encourage you to reach out to them.
And we've had some conversations with superintendents recently where they're on board, their boards are, what did he use? Resistant is what he said. So I think community members can help talk the boards into it too.
Absolutely.
I was at a meeting this morning with, at a family collaborative meeting, and I think it's feeling a little over, and I was talking with one of the superintendents, and they're a little overwhelmed by it, I think. And so it's really going to take some encouragement and we're there with you. We're going to work through this. Because not all school systems have the administrative support that others do. Some have stronger administrative support. So I think it is falling on a lot of us to help and be there for them.
I was going to ask a question. Gwinnett County Coalition, or Gwinnett Coalition of Gwinnett County and Gwinnett. Anyway, so we've been having conversations with our local Gwinnett County Public Schools, and we had representatives on here earlier. I think they might have dropped up because of the time, and there may still be somebody that I don't know the name, but, and also our public health team has been represented in both of these webinars. So we're trying to ready our community. But to the board question, is there a way to offer maybe an education session similar to what you have provided to this group to the boards if there was an interest in learning more? Because I do think that would be helpful.
I've done many of those all over the state. Matter of fact, they would call me up if you just can join us for 15 minutes at 7 o'clock at night and just explain to the board what it is that we're trying to do. Then I've done that. We've done that, and we're here to do that and to use Sandy and other groups who've been really successful in explaining the value of this to the school board. We're just living in really difficult times right now. When reason just common reason doesn't play out the way it should, right?
Well, it's that, and it's a lot. I mean, school systems are
it is. But when you're talking about achievement for students, I always say you need to stay on message, no matter what people come at you with. This is in the best interest of our children. No matter what your objections may be, I'm just going to circle back around and say, this is in the best interest of our children. It's up to us to make sure that we provide resources and an infrastructure that maximizes their achievement. And if you can come up with something better than that, you let me know. But this is what this is about. And so I stay on message, and I just encourage you to stay on message when you come up against this opposition.
As Dr. Johnson says, these are our children. And I would just add that, utilize her experience, and she's the ace in the hole. She won't brag on herself, but we lovingly refer to her as the mother of school-based healthcare in the state of Georgia. She and Ruth Ellis's guidance from day one helped us, and that data sheet is as overwhelming as it looked, really taught us early on. We used to hate to have those meetings and have to go over that data early on, but it helped make us successful and be able to be successful as a healthcare center. But early on, and in all of our projects that we've started, we have had our own PowerPoint. We have drilled down as FQHC. We have a lot of good data, and we specifically drill down on that data for the school system, for the area we're talking about. And we had our PowerPoint polished off, and we met with several groups and the school board probably 2 to 3 times prior to getting the MOU with the school board. And so, but that also helped us with support. As a friend of mine down in Polk County says, have their skin in the game, so to speak. So, never be fearful of, it's not a bad thing if you're being asked to present a lot. It's really just building that consensus in the community. And sometimes it takes a few times. Interestingly enough, the board member that voted against Catoosa County because he was Catholic and he thought we would be handing out birth control, now came to us and asked if we could, because he's at a college and career academy, if we could put a school-based healthcare in his school. So he's come 360, and he sees the value of it. So I always say we have to be like Dr. Seuss. It took 13 times for him to submit his books before he was published. So you just have to be Dr. Seuss in the world that's not sometimes.
Well, and it's a big ship. It's the largest school system in the state. So we're patient, and we believe in what this could do. And I think philosophically they do too. It's just, we've got to just continue to work at it and continue to seek the understanding and be able to articulate the value. So. Actually,
I've hosted your superintendent at Doraville United School-Based Health Center, and so I've worked with Gwinnett for a long time. I mean, the leadership has changed dramatically over the years, and so it's like you have to start from scratch again. But I think you have enough interested parties within the school system to
Mhm.
put a little pressure on the school board in order to
That- So you spoke with Dr. Watts, is that,
I cannot remember anybody's name, but
okay, well, because the past couple of years, we have a new superintendent.
okay, it's probably, he's probably new. Yeah.
Uh-huh,
Mhm.
but he's anyway, he's great.
I think
So-
we hosted them last year though, if I can recall, but
well,
anyway.
then you might have,
Mhm.
He's he's got good shoes. That's Superintendent Watts, right, Renee? He always has really nice sneakers.
I said, right? I mean, he's
remember.
always very dapperly dressed. Yeah, I think
Yeah.
you're right. I'm not a shoe person, so I don't always look at shoes. So,
I check out everybody's outfit at all times. So
yeah, no, he's always very,
Remember.
very well dressed. Yeah. All right. Well, thank you.
You're welcome.
Thank you. Thank you, Dr. Johnson and Sandy. This has been wonderful. Like I said, we'll share the video with all those that could not attend today, and those of you that were able to attend that want to share to your partners. We'll get that to you as soon as it downloads on Zoom. Thank you so much for all of the help and excitement and everything that you've built in the state already and continue to build. So we're very grateful.
It's been my pleasure, as always.
And I hope the traffic gods are with you.
Okay, yeah, I'm on my way. Bye, you guys.
Bye. Have
Bye.
a good day.